Can you hear us now?
Yeah, I hear you. Right.
Can you hear me now?
Yes.
Okay.
And we'll give everyone just a few more minutes to come in. Okay, good morning, everyone, and welcome to the Fall 2020 Medical Series. These talks are meant to increase your medical knowledge and help you form a better relationship with your doctor so you can have a little bit more to talk to them about when you go visit them. Today, we'll be hearing from Dr. Sean Daly. He's a specialist in gastroesophageal. How do you say that word, doctor?
Esophageal.
Esophageal, okay. He's a specialist in gastroesophageal reflux disease and diseases of the upper digestive tract with training in advanced minimally invasive surgery. For the lecture today, we'd like everyone to turn off their video and mute their audio. It'll just make the playback go a little bit better. If you have any questions, please raise your blue Zoom hand or type them into the chat, and when there's an appropriate time, we will ask those questions. Okay. So please, Dr. Daly, please go ahead. Welcome.
Right. Good morning, everyone. It's really nice to be here today, and I appreciate the opportunity. Today, I'm going to talk about gastroesophageal reflux disease, specifically looking at early detection and treatment and why that's crucial, and that everyone should be aware of this disease. I'm a foregut and bariatric surgeon, so this topic really hits home for me, and it's one of my passions to talk about and to teach and to discuss with patients. So I do have one disclosure. I'm an educational consultant for a company called LivsMed who creates articulating instruments, but this has absolutely no conflict whatsoever for this presentation. So a couple of objectives today. I do want to give a little bit of a background and talk a little bit about what I mean by gastroesophageal reflux disease. I do want to talk about how we diagnose gastroesophageal reflux disease. I do want to talk about how we treat gastroesophageal reflux disease, and then talk a little bit more about what's Barrett's esophagus and why this is an important topic, and then how we treat Barrett's esophagus, and then talk very briefly about some early esophageal cancer and treatment and why it's really important, as the title of my talk discusses today, to know about this disease and diagnose it early. So what is gastroesophageal reflux disease? Well, it's defined as abnormal reflux of gastric contents. Can often be acid, but doesn't have to be. It could be bile or any type of other liquid material in the stomach that refluxes back up into the esophagus. And why this is important is 20% or 1 in 5 adults suffer from heartburn symptoms. And what are those symptoms? Well, burning pain in the chest, nausea can be associated with reflux disease, regurgitation, which is the immediate bringing back up of food that you've just ingested, bitter taste in the back of the mouth. It's often when you're lying supine at night or when you wake up in the morning, and a dry cough, as the reflux actually can get up into the vocal cords and cause a reaction. So what are the risk factors? Who are the people that may develop gastroesophageal reflux disease? Well, obesity is a large risk factor, and I'll go into a little bit of why that is very shortly. A hiatal hernia, which I'll describe in just a little bit too, puts you at a very high risk of having gastroesophageal reflux. Pregnancy, as we increase our abdominal pressures, as the uterus and the fetus grows, this puts us at a higher risk. Any connective tissue disorders, which can weaken the bottom part of the esophagus and allow reflux to passively reflux into the esophagus, is an also a risk factor. And then delayed gastric emptying. If our stomach isn't emptying correctly and the gastric acid isn't able to move forward like it is intended to, it can build up pressure and actually come up the esophagus. So why is gastroesophageal reflux important? Well, there's a stepwise progression of this disease. And I think that's one thing that a lot of people don't realize, but this being something that I am passionate about, I've actually seen patients along this whole paradigm here. So what we see a lot is uncomplicated GERD. And these are patients who come in and they have the reflux symptoms and they have an endoscopy done, which we'll talk about later on why that's important. And they don't have any damage or any complications of the reflux disease. It's mainly symptoms. Now, once our esophagus has been exposed to acid for a while, our esophagus does not normally see that caustic material. So what it does is it causes inflammation. And that inflammation of the bottom of the esophagus is graded. It's called an OLLI classification, and the grades go from A, B, C, and D. Grade A is the least amount of inflammation, all the way to class D, which is the most severe inflammation of the bottom of the esophagus. Now, once we have chronic inflammation and we progress through mild inflammation to severe inflammation, what our esophagus actually does is it says enough is enough. And what it can actually do is it can change the cells that the lining is made up of. Our small intestine normally sees a lot of gastric acid because that's the way the acid normally flows throughout our body. So they have a different type of inner lining. When the esophagus is constantly exposed to acid, which it normally is not supposed to be, it can actually change the lining to look like the small intestine. So when we're doing our endoscopies, we'll actually go down with the camera and we'll take a look, and the bottom of the esophagus actually looks like the small intestine. And that's called Barrett's esophagus. And you can imagine when we have a lot of cells that are constantly changing what they're made of, that can get very disorganized. And what that leads to is dysplasia and esophageal cancer. So this is a very predictable and very well-studied progression of this disease. And it's really important that we are able to stop this progression and actually reverse this progression back to uncomplicated GERD, or actually no GERD at all. And I'll talk to you a little bit about how we're able to do that. But I want to talk a little bit about how we get GERD. Now, I did mention some risk factors earlier, but really GERD is the breakdown of a protective lower esophageal sphincter. So at the bottom of our esophagus, right at the area where the esophagus connects to the stomach, we have a little sphincter that normally keeps food flowing forward, but prevents acid and liquids from refluxing back up. And there's three components of that sphincter. One is there's a high pressure zone at the bottom, and that's due to having the bottom of the esophagus in our abdomen. Usually that pressure is about 10 millimeters of mercury or more, and that's enough to prevent acid from passively refluxing back up. Now, due to, or also in a conjunction with that, and why we're able to have a higher pressure at the bottom of our esophagus, is that about 2 centimeters of that intra-abdominal esophagus needs to be located in the abdomen. And that 2 centimeter difference between the chest and the abdomen creates that pressure gradient. And the length of the entire lower esophageal sphincter is usually about 2 centimeters. Now, when we lose any of these components, it puts it at a risk of reflux. We can lose length of the lower esophageal sphincter by a process called effacement, which I'll talk about shortly. And we can lose our intra-abdominal pressure by a hiatal hernia. If you remember back, that was one of our risk factors. To the right here, this shows a hiatal hernia. This is the actual connection of the stomach and the esophagus. This line right here that the bottom arrow is pointing to is our diaphragm. And the double arrow should be below that diaphragm. And as you can see, the stomach is herniating back up into the chest. And that is one of the biggest risk factors for losing this lower esophageal sphincter and having reflux symptoms. Now, I did talk a little bit about effacement, and this is a really important concept. What we've seen through a lot of studies is that most of the gastric acid actually resides in a little acid pocket at the top of our stomach, conveniently located right next to the lower esophageal sphincter. And this goes to why we have a lot of reflux, or we feel reflux symptoms after eating, and why we have reflux symptoms after we eat a huge Thanksgiving meal, which is going to be coming up. So normally our sphincter on the left picture is about 2 centimeters, and the bottom of the sphincter for approximately a couple millimeters is exposed to the stomach in this acid pocket. Now, when we eat food, we actually distend out our stomach. And as we distend out our stomach, it distends out the lower esophageal sphincter. We can see this on the far right picture. And by the stomach distending out and the lower esophageal sphincter being exposed, it slowly breaks down that sphincter to a point where we no longer have a 2 centimeter high pressure zone. We have much less than 1 centimeter, and that essentially destroys that lower esophageal sphincter, and we can get acid flowing back up into the esophagus. And this was well studied by a Tom DeMeester, who is a very, very prominent surgeon in esophageal disorders. Now, the most important thing is a proper and thorough workup for reflux disease. GERD symptoms are very nonspecific and could be related to many conditions. If you remember back, nausea, regurgitation, burning sensations, those could be related to many, many different pathologies, including ulcers in the stomach, or any type of motility disorders of the esophagus. So we can't rely just on symptoms alone. Because of that, there was an advisory panel put together that made recommendations on what would be the appropriate and thorough workup for reflux disease. And these are the 4 components that they described. And I'll go through each one individually so we understand them. But an upper endoscopy is crucial. And that's where we go in with a camera and take a look at the health of the esophagus, health of the stomach. A barium esophagram, that is essential. And what that is it's where we swallow contrast, and we have a video, and we have a X-ray images of the contrast flowing through the esophagus and into the stomach. The hiatal hernia picture I showed you earlier was an example of what we can see on a barium esophagram. pH monitoring, specifically a Bravo capsule, that is the diagnostic measure that can tell us if we have reflux disease or not. And then esophageal manometry, which is a catheter that's placed, and it will give us a readout in terms of the function of the esophagus. The esophagram, the upper endoscopy, it can't tell us how our esophagus is functioning. And having a manometry and knowing the function of the esophagus, which could be broken down by chronic reflux disease, is extremely important in making treatment decisions. And one of the other things that I have added is, I think is really important, is GERD HQRL scores, which is the health-related quality of life scores. It's a subjective scale. And I think that's important too, because while we look at objective data to diagnose GERD, one of the most important things to patients and everybody should be their quality of life. So I want to make sure that after we diagnose and treat gastroesophageal reflux disease, that patients have a better quality of life and they feel better, because that's one of the big reasons we're doing this. Now, I want to first talk about upper endoscopy. And it's really the most common first diagnostic test that's prompting a surgical referral. Most of the patients come in to see me because they've had GERD symptoms, they've gotten the endoscopy, and they've actually found damage to the esophagus. That is normally what prompts a surgical involvement. So normal endoscopy is seen in 60% of patients with an abnormal pH study. So if you do have reflux disease and you do have what we'll talk about in a few minutes, a Bravo that confirms that, 60% of patients may have an upper endoscopy. And that goes back to that patient population of uncomplicated GERD and the reason that we can't just rely on symptoms alone. Now, we do have the LA classification for esophagitis. The picture here on the left side of the screen is the most severe. That would be an LA class D esophagitis. And that's due to longstanding chronic caustic issues with the esophagus. If you can see right in the center of this picture, there's a little black dot. That's actually the connection between the esophagus going into the stomach as we're looking down the esophagus. Now, the upper endoscopy is also important because we have to rule out and we have to identify complications of reflux disease that may not be appropriate for a simple operation. One of them is peptic ulcer disease, which means ulcers in the stomach, which can mimic reflux disease. Barrett's esophagus, we want to know where on that progression we are. Eosinophilic esophagitis, which is not treated by surgery, and esophageal stricture. And then here on the left, this is esophageal cancer in a patient who came in with Gerd symptoms. Now, moving on to the barium esophagram, this has got great value in operative planning. Patients can have reflux without a hiatal hernia, although it's less common, but it's really important to obtain the barium esophagram to look for several different conditions. One of them would be esophageal shortening. I have seen patients with the entire stomach in their chest, and if that's going on for a long time and is very long standing, then what can happen is the esophagus can actually be foreshortened, and that's a consideration during surgery. We need to know if there's any esophageal diverticulum, if there's a hiatal hernia, which is again shown on the right. It gives you a very crude estimate in terms of the esophageal motility. It's not a diagnostic test of the function of the esophagus, but you can get a bird's eye view of how the contrast is flowing. Whether there's a gastric volvulus, this is often seen when the entire stomach's in the chest, and then delayed gastric emptying. You can see how quickly that contrast does empty out of the stomach. And remember, delayed gastric emptying is a risk factor for GERD. Now, one of the most important diagnostic procedures that can give you the absolute confirmation that you have reflux disease is a pH monitoring. Specifically, and most commonly, we use a Bravo capsule, and it's really considered the gold standard of diagnosis. It must be performed off medication. So I have to tell patients that, 7 days before they have this test, they have to go off of their PPIs. And if that patient is extremely symptomatic, what I can do is I could offer them H2 blockers, and that's more your Pepcid. They can stay on that, but they still have to come off of that 3 days before, because we need an accurate measure of the reflux and the acidic content of that reflux, and the PPIs mask that. I usually do not recommend placing these if you have class C, class D, or Barrett's esophagus. Those will not completely diagnostic of reflux disease. Is pretty much guaranteed reflux disease when you have those conditions. But again, the gold standard remains pH monitoring. Impedance is a test that we can do to look at a patient who has extremely bad esophagitis and or extremely bad symptoms and have a Bravo test done, and the Bravo comes back showing that there's no acid reflux. And remember, going back, I talked about there's other things that can reflux into the esophagus, and that could, one of the most common is bile. Impedance doesn't look at the acid content or the acidity of reflux that's coming to the esophagus. What the impedance actually does is the impedance is measuring any type of reflux that goes into the esophagus. It's measuring the actual fluid. So if you have bile reflux that's not acidic, the impedance will pick it up, or the Bravo will come back as negative. Now, all of this data, we look at the pH, we look at how often, how long the episodes are, how much acid is going past this Bravo capsule. It's put into a mathematical equation. And that mathematical equation spits out a Demeester score. If you remember Tom Demeester, he's the one that came up with this during his studies. And a score of 14.73 or less is not considered pathologic gastroesophageal reflux. We all have a little bit of reflux throughout the day. So that's where the score is not 0, but it's low at 14. Anything above that is considered excess reflux and should prompt a conversation about what we can do. Now, this Bravo capsule is placed during endoscopy, and after about 5 or 7 days, it falls off. We pass it in our stool, and we never have to go back in and get it. And the pager is something that you wear during the test itself. When you have symptoms, you hit a little button on the pager so we can correlate your reflux symptoms with any symptoms that you may be feeling. After 2 days, you send back the pager, we read all the data, and we come up with a score for you. We'll usually have that by your consultation, so we'll be able to talk about what that means. And the last one I want to talk about, which is a possibly important part of the workup. Now, the Esophageal Advisory Committee did talk about this and suggest that this be a modality in the workup. But this is something that's selectively used by most surgeons. It has very limited value in diagnosis, but it's really critical in surgical planning in patients. And I use a selective approach to this, and this is my algorithm, and it really boils down to dysphagia. And if the function of the esophagus is significantly altered, that is felt by a patient as dysphagia, or the inability or the feeling that you're not able to swallow your food properly. Now, if you do have dysphagia symptoms, or you're considering a LINX, which we'll talk about later, then you need a complete manometry. We need to know your esophageal function profile. If, in fact, you come in and you say, I have absolutely no dysphagia, I can eat my food, I swallow it, I have no problems with that, then we do something called an endoflip. An endoflip is during the time of the endoscopy, we put a little balloon across that lower esophageal sphincter and we blow up that balloon. As we blow up that balloon, we measure the pressures that are inside that balloon, and it'll tell us if indeed you may have an esophageal issue. If you don't have symptoms and the endoflip is completely normal, then you're done. It's almost a screening test. If you don't have symptoms, but the endoflip comes back as abnormal and we're not quite sure, you go on to your complete manometry. So having the screening test does eliminate some people from having to have a manometry done, which is important because people always remember the manometry test. It's putting a little catheter down the nose, and most people don't like that. And I agree. So when we're talking about the basic treatment of gastroesophageal reflux in somebody who's been diagnosed, there's two different theories or two different ways that we can go about doing that. If you come in and you have mild and intermittent symptoms, or even a very low grade esophagitis, a grade A and maybe sometimes in a grade B, we do a step-up approach to PPI therapy. And what that means is we'll start with the lowest dose of PPIs, and we titrate up the dose until your symptoms go away. Now, on the other hand, if you had your EGD and you have very severe symptoms, or you have very erosive esophagitis, or you're borderline getting to that Barrett stage, then what we do is we employ a step-down approach. And what that means is we start you on the highest dose there is. And that's just to completely get ahead of the disease and stop that progression since you have erosive esophagitis. And what we'll do is we'll titrate back that dose until your symptoms start to reappear. And when your symptoms start to reappear, then we put you on the dose that was one higher where you didn't have any symptoms. That's usually the best way about going about that, because we really want to interrupt that progression that we talked about earlier. We usually do a standard dose for about 8 weeks, and that heals esophagitis in about 85% of patients. If you ever get to the point where you're on BID dosing and your symptoms are barely controlled or not controlled, we consider that failure of medical management. We can't go higher than giving you the pill twice a day at maximum doses, and that should prompt a referral to a gastroenterologist or a surgeon, because the medicine's not going to be effective. Now, considerations for endoscopy and surgery. Symptoms: if you have regurgitative reflux disease, meaning that when you swallow your food, it goes into your stomach, and rather than just acid coming back up into the esophagus, it's actually food particles that you just ate. Or if you have a chronic cough, those are usually not well controlled by a PPI. The PPIs, what they do is they neutralize the fluid to acid. But if you're having bad symptoms of kind of food coming back up, a PPI is not going to do anything for you. If you have non-acid reflux and symptoms and you're on PPI therapy, this would be an endoscopic or surgical candidate, because the PPI therapy is not going to be effective in acid reflux that is not acidic. Symptoms in a large hiatal hernia: no matter how much PPIs you take, you can never fix a hiatal hernia without surgery or endoscopy, and that's going to constantly keep you at a risk of having reflux, although the PPI will be neutralizing the acid component. Poor patient compliance with medical therapy. If no one wants to take their pills, maybe a surgical intervention where we can stop the reflux is best. Cost of medical therapy, side effects of medications, or symptomatic young patients who don't want to be on a PPI for the rest of their life. These are all good candidates. These are ideal candidates for an endoscopic approach, and then we'll talk about the surgical approaches in a few minutes. Patients who suffer from heartburn, regurgitation, or both, you obviously want to treat somebody who has symptoms so you can make them better. It's hard to actually make somebody who feels perfectly normal feel better. Esophageal peristalsis has to be adequate in patients undergoing endoscopic therapy. You have to have a diagnosis, so you do need to have a positive pH monitor. Now, for endoscopic approach, we concentrate on non-erosive esophagitis. If you have class C and D, we often don't start with endoscopic management. You have to have failed medical management, or you have no significant anatomic abnormality. If you have a very large hiatal hernia, endoscopic approaches are usually not the best way to go. So radiofrequency ablation, or what's called the Stretta procedure, was first approved by the FDA in 2000. And what it does is it induces collagen contraction at the lower esophageal sphincter, and it reduces postprandial LES relaxation. So after we eat, we have these transient relaxations of our sphincter we talked about, and that allows that acid to sneak up into the esophagus. This reduces that, and it decreases the compliance of the lower esophageal sphincter. Kind of bulks it up in kind of plain terms. And this is what the procedure entails. We put down, you can see in picture 1, a catheter that's placed about 2 centimeters above the Z line. A Z line is the transition from the esophagus into the stomach. 4 needle electrodes are deployed, and they're about a ½ centimeter in length, and they're deployed into the muscle that is surrounding that balloon. And then we deliver energy for 90 seconds, and we're achieving 85 degrees Celsius when we deliver this energy. The catheter is rotated, and this method is repeated, and it creates 56 lesions. It takes about 35 minutes to complete. Now, Stretta is a procedure that we use, but it's not very used often. Lots of times we'll use them in patients who are not candidates for a surgical intervention and they're failing medical management. It gives them significant reflux control. It's not very durable, but it may need to be done multiple times. So it's not the ideal approach, but it does fit into kind of our treatment algorithm for a select group of patients. Now, something that's a little bit more durable, a little bit more efficacy when it comes to reflux control is a new procedure. And when I say new, within the last 10 years, 15 years now from the first one, about 13 years since it was approved, about 10 years since it became widely popular, is something called the transoral incisionless fundoplication, or the TIF procedure. And it's performed with an EndoFix device, and this is shown below. This is actually put down the esophagus, and using the endoscope, which goes through this device, we're able to recreate an actual valve at the bottom of the esophagus. And I do have a short 2-minute video or so here to show you exactly what the TIF procedure is. All right. So I kind of want to move on to talk about the surgical approach to reflux disease. And this is a slightly different patient population than would be eligible for an endoscopic therapy. And these patients usually have very refractory esophagitis. They've been dealing with this problem for a very long time. They may have a benign stricture. Patients who have Barrett's metaplasia, which we talked about, we're getting closer and closer along that progression to worrisome conditions, or a hiatal hernia, which we talked about the endoscopic therapies not being able to control very well. Refractory symptoms despite medical management, same as endoscopic. Unable to tolerate medications, non-compliance, or unwilling to take lifelong medications would put a patient into this group where surgical approach might be appropriate. And then any kind of GI and non-GI or respiratory symptoms are very good and very well controlled, and in studies have shown to be the surgical approach to be very efficacious. So one of the technology I want to talk about first is a newer technology that we're using, and this is called the Lynx anti-reflux symptoms. And it's a lower esophageal sphincter magnetic augmentation. And this is an intraoperative photo that I took after placing a Lynx device. If we look over to the right, what I mean by magnetic augmentation or the Lynx bracelet is this chain of beads that will be placed around the esophagus. If you look over on the left, you can see that we have placed this around the very bottom of the esophagus. And what it does is it creates a higher pressure in the esophagus when the esophagus is at rest and closed, and the Lynx bracelet, as shown on the right, is in a closed position. Now, these are magnets, and as you swallow your food and the food bolus goes down your esophagus, and that pressure of the food bolus being pushed through will actually open up this bracelet and allow the food to pass. And we get a manometry in these patients because we need to make sure that the pressure behind the bracelet, or the pressure that's pushing the food bolus through, is strong enough to open the actual bracelet itself. Otherwise, obviously, we're creating an obstruction, and patients who don't have a fully functioning esophagus may not be able to push through this bracelet. But the opening pressure of this bracelet is greater than the amount of pressure needed for passive reflux to flow back up into the esophagus. So it's kind of a happy medium where the bracelet remains closed at rest and won't open from reflux pushing up against it. However, when you eat food, it opens up and allows the food to pass through. And I have a short video just about the length of the other one that will show you what I mean by this and show it in action. All right, so there's a short video on just how it actually works. And then we actually have a really good study that I wanted to talk about in terms of how well the Lynx device works, and really why I think it's an important part of reflux control. So like we talked about, it's a small implant. It's comprised of interlinked titanium beads with magnetic cores. It was developed by Torax Medical, which is now Ethicon, and that was developed in 2002. It's FDA approved in 2012, so it's been around for about 8 years now. The initial clinical trial of 100 patients, which led to the approval by the FDA, it showed that 92% of patients are free of daily dependence of PPIs after placing the Lynx device. 90% of patients experience reduction in total acid exposure time, and then 93% of patients achieve significant symptom control. It's very good at treating regurgitation. It's moderate to severe regurgitation. That subgroup group of patients in the study was about 57%, and it went down to 1% afterwards. One of the biggest benefits of the Lynx device compared with the typical fundoplication is the decrease in what we call gas bloat syndrome, or the inability to belch or the inability to vomit. at baseline, prior to any intervention or any LINX procedure, none of the patients described an inability to belch or an inability to vomit. Quite opposite, actually, as the lower esophageal sphincter is open. This is actually, you get excessive belching and regurgitation. 12 months after placement of LINX and 24 months after placement of LINX, very few patients, 1%, proceeded to develop any of these symptoms or what we would call gas bloat syndrome. Now, one of the most tried and true, long-standing surgical interventions that we use is something called a fundoplication. There's many different types of fundoplication. There's full fundoplications, partial fundoplications. Some of the names are door, toupee. I just want to spend some time for a second talking about a Nissen fundoplication, because the Nissen fundoplication is the most common fundoplication that we perform. And this is considered a full fundoplication. As you can see on the pictures on the left, we actually dissect out the bottom of the esophagus and fix any hiatal hernia that may exist. That's what's meant by tightening the hiatus. The esophageal sphincter, you can see, is about 2 centimeters into the abdomen, and we need at least 2 centimeters in order to fasten a appropriate fundoplication. And we actually grab the top part of the stomach called the cardia or the fundus, and we wrap it around the back part of the esophagus. Once we wrap the top part of the stomach around the esophagus, we grab additional stomach that's on the other side of the esophagus and bring it around the front. So as you can imagine, we're taking the top part of the stomach and essentially creating a wrap around the bottom of the esophagus. When we sew that together, what we're doing is we're not actually using the top part of the stomach to put significant pressure on the bottom of the esophagus. That's where the gas bloat syndrome comes in if these fundoplications are fastened too tight. But what we're doing is we're creating a valve. This picture on the right shows what a fundoplication looks like. It's a tissue valve that's created by the twisting of the stomach around the esophagus. It's not composed where we're putting external pressure on the esophagus. And then once we've mastered that technique laparoscopically, where we really were able to increase our learning curve in terms of how tight to make fundoplications, and then understanding it's more the twisting nature rather than how tight the valve is, gas bloat syndrome, even with a Nissen fundoplication, has come down significantly. And the Nissen fundoplication is a great operation. It's 96, 97% effective, meaning that no further reflux disease and no medications. Now, I do want to talk about Barrett's esophagus. Barrett's esophagus is defined as a condition in which any extent of metaplastic columnar epithelium, and that's what the epithelium or the inner lining of the small bowel is, that predisposes to cancer development, replaces the squamous epithelium, and that's normally what the esophagus is. If you're looking down the esophagus, this lighter mucosa in the foreground is normally what your esophagus looks like, and that's squamous cells. If you look a little bit deeper down, the more salmon-colored inner lining is Barrett's esophagus, and that's columnar. Now, the progression to adenocarcinoma, you have your squamous esophagus on the top, chronic inflammation, that's our esophagitis. Barrett's metaplasia is in the middle. And when you have all of these cells changing exactly what they're made up of, like we talked about earlier, you can get dysplasia. It starts with low-grade dysplasia, then high-grade dysplasia, and then we progress to adenocarcinoma, which is the bottom picture. Now, there's several studies out that shows that Barrett's esophagus, once it's diagnosed, has a progression to cancer risk. So it can be considered pre-malignant. Now, the uncomplicated Barrett's esophagus, it's got about a 0.3% per year average progression into or risk of adenocarcinoma development. When we actually look at Barrett's esophagus a little bit closer, we do break it down into 3 stages, and that goes back to the dysplasia. So Barrett's without dysplasia, the 1% cancer risk, like we talked about just in the previous slide, is about 0.3%. 10 years, it's about 3% of developing and progressing to adenocarcinoma. If you had identified low-grade dysplasia in your Barrett's, you have a 3 to 5% risk of getting cancer in 1 year and a 50% in 10 years. And if you have high-grade dysplasia in your Barrett's esophagus, it's a 10% 1-year risk of cancer and 100% at 10 years. And this is if it's gone untreated, which is very important as to why we treat these. And this just shows the divergence in terms of development of cancer. The y-axis being the percentage of patients who develop cancer, and on the right is the years. So you can see at 10 years, if you have high-grade dysplasia and that's untreated, you will develop adenocarcinoma of the esophagus. Risk factors for progression to that cancer. We see that males, especially younger males, with a family history and Caucasian race are at highest risk of progressing to cancer once they have reflux disease. Smokers, obesity, and then when we look at the Barrett's itself, how long you've had the Barrett's, if you have a very large hiatal hernia associated with it, because remember going back to what we talked about earlier, if you have a hiatal hernia, unless the hiatal hernia is fixed, you're still going to have reflux disease. And then the lengths of the Barrett's esophagus. And when we talk about length, there is a study out that shows this correlation. So this was a multi-center outcomes project, and it was entitled Non-Dysplastic Barrett's Esophagus Progresses to High Grade or Cancer at Significant Elevated Risk Based on How Long the Barrett's Esophagus is. So if you have a less than 3 centimeter length of Barrett's esophagus, then you have 0.3%. If you have a greater than 13 centimeter length, if nearly the entire bottom third of your esophagus happens to be Barrett's esophagus, you almost have a 2.4% chance per year of developing cancer. And how do we determine length? Well, there is an actual classification system for that. It's called the PROG system. It's a C and M criteria for the classification. What C is measuring the circumferential extent of the metaplasia. So this is where completely around the bottom of the esophagus, you have Barrett's esophagus. So this would be a C2. But what happens is you have these spikes of Barrett's that come higher up. Now it's not circumferential, but they do reach a maximum of 5 centimeters. So this would be considered a C2 M5 lesion. And that's shown right here. Circumferentially, 2 centimeters above, you have Barrett's esophagus, but then you have these spikes or these islands that come up. And those are important to consider. Now, you need an experienced gastroenterologist when you're looking for Barrett's esophagus, and there's different techniques to an endoscopy. Simply going down with a camera and taking a look just on gross examination. Sometimes Barrett's esophagus is hard to diagnose and is missed. On the left side, you have a picture of an endoscopy that's done with just normal camera view. And you can see it looks relatively normal. There's no standing out salmon colored mucosa like we saw in some of those previous slides, nothing obvious. But when you use something called narrowband imaging, and it's just a different waveform of the light, you can see that you have Barrett's esophagus, and you wouldn't have seen that without using the narrow band imaging. So it's very important that you have these techniques and you have somebody experienced with these techniques when they're we're getting worked up for reflux disease. Now you can even go further, and there's a technique called Cellvizio, where you can actually look to see if there's a high risk of dysplasia in the cells just using the endoscopy. On the left, this is using narrowband imaging and Cellvizio, and what you see is you see relatively normal looking cells. Now, if you took a biopsy of this Barrett's esophagus, what you're going to do is you're going to biopsy this area and it's going to come back as having no dysplasia. But if you look very closely and you use Cellvizio, you can see the cells on the right are much different than the ones on the left. The ones on the right have a high risk of dysplasia. They're very disorganized. This is the area you want to do your biopsy, because if you biopsy just the cells on the left, you're going to say no dysplasia. If you biopsy the cells on the right, you're going to get dysplasia. So it helps focus biopsy so you get most accurate diagnosis. Plus, you need somebody who's going to spend the time looking. Endoscopists who take longer than a minute per centimeter when looking at Barrett's. So if you have a 3 centimeter segment of Barrett's, at least 3 minutes, which is actually a long time while you're staring at something, they do better in finding suspicious lesions within that Barrett's. 54% compared to 13% who actually follow the 1 minute rule. And you can see that on the right. If you spend less than 1 minute per centimeter, the suspicious detection rate or the cancer rate is determined to be about 13 and 6%. But if you abide by that 1 minute per centimeter rule, and you're really looking very closely over a long period of time, you actually can uncover more lesions and more dysplasia. Now, treatments of Barrett's esophagus, when you have Barrett's esophagus, one of the first treatments is radiofrequency ablation. And what that is we'll actually go down with either of these caps or either of these instruments that you see here on the screen. The one on the left is circumferential. It can radio frequency ablate circumferentially. The one on the right doesn't do circumferentially. It does little spots. So you can actually clean up little areas or little islands with the one on the right. Now, it's really important to intervene because this is the ultimate thing that we really want to prevent, right? We don't want anybody to progress to adenocarcinoma. The survival for adenocarcinoma is only 17%. And most likely the reason for that, or really the reason for that, is that esophageal adenocarcinoma is diagnosed very late, usually upon symptoms. And when you have symptoms such as dysphagia or inability to swallow, it's due to a tumor being so large that you can't pass food through it. When that occurs, the survival from something that advanced is significantly lower. And this differs from something like colon cancer, where we have surveillance, we have screening modalities, and we can catch these cancers early. And we can actually intervene early and give patients higher survival. When I talk about early esophageal cancer, I'm talking about the staging system that we employ called TNM. T stands for how far in the esophageal wall the cancer is invading. N talks about how many lymph nodes are involved. And M talks about metastatic disease, or if the disease has traveled anywhere else. When I'm talking about early esophageal cancer, I'm specifically talking about T1A or less, meaning that it hasn't fully penetrated through and into what we call the submucosal layer. And that's an important breakpoint in the determination when we're talking about staging. And the reason is that we have endoscopic resection and we have esophagectomy when it comes to reflux. And when we're talking about early esophageal cancer, that T1A or less, and we're comparing outcomes between the endoscopic resection and RFA versus an esophagectomy. They took 61 patients who had an esophagectomy and 40 patients who had the endoscopic therapy. And when you compared the endoscopic therapy to esophagectomy, it was associated with lower morbidity, 39% versus 0%, and similar survival, 94% at 3 years, again, for early cancer. Endotherapy was concluded for high-grade dysplasia and T1A or less cancer has similar survival, but significantly decreased morbidity than esophagectomies. Esophagectomies are a very large and major operation to undertake, which is an important reason to be able to detect and to treat these early. Once you are diagnosed with T1B disease, though, then esophagectomy becomes the standard of choice. And the reason is that when you go from a T1A lesion to a T1B lesion, T1A, the chances that you have lymph node metastasis, which is not going to be treated by anything that you do endoscopically, is extremely low. When you get T1B, you can see the chances of lymph node disease becomes very high. And esophagectomy is the only treatment that can remove the lymph nodes, which is extremely important when you have positive lymph nodes. That's the reason that T1A and T1B becomes so important. Now, there are some guidelines for treatment disease, and these are well studied and widely accepted, but some people do vary a little bit from these suggestions. For non-dysplastic Barrett's, surveillance or ablation in selected individuals, most people do ablation. Low-grade dysplasia, which has been confirmed, obviously we're going to do an endoscopic ablation. High-grade dysplasia, you can do an endoscopic eradication, which means not just ablation, but you actually go down with the endoscope and can cut out the tumor. But that's only appropriate for high-grade dysplasia. T1B, and they're starting to do some studies on T1B, but it's not widely accepted. The endoscopic resections are appropriate. T1B, for the most part, T2, T3, and anything greater than that, or any lymph nodes that are known to be positive, surgery is the choice. So I just wanted to thank you for taking the time to listen today, and I'm happy to answer any questions that may have come up.
Okay, we do have a question in the chat, but if anyone else has a question, please raise your blue Zoom hand or type it into the chat and we'll ask it for you. Okay, so the question is, what if you've changed diet to dairy-free and gluten-free, but still have burping and belching? Is that an indicator of progression to bigger problems?
Oh, no, and that's a great question. So I wouldn't go as far as saying that that's an indication for progression to large problems, but what that could be an indication for is that you have, or there is an anatomic issue as to why you're having reflux disease. Now, if you do not have any anatomic alterations, meaning no hiatal hernia, then changing diet to avoid triggers of anything that may increase reflux or reflexogenic, we call it, diets, can improve your symptoms considerably. Now, if you do that and you're not getting much response from that and you're still having symptoms, it's suggestive to me that there's a hiatal hernia or the crura, which is what protects around the esophagus from acid reflux, may have some laxity to it, and you have an actual anatomic reason as to why you are having the belching and the burping and potentially an underlying reflux.
Okay, is there a cause and effect relationship between GERD and tight clothing?
Not that's been studied or not that I'm aware of. So increasing intra-abdominal pressure, like we talked about with pregnancy and obesity, can increase GERD symptoms. As we put a lot of pressure externally on the stomach, it can cause reflux to push up into the esophagus because we're increasing that pressure or that gastric pressure up into the esophagus. Tight clothing is not going to be a significant nidus to increase that intra-abdominal pressure. So I don't see, and there hasn't been any suggestion that there is a increase in GERD due to tight clothing.
Okay. What are the side effects of long-term use of PPIs such as Nexium or Prilosec at the 20 milligram dose?
Okay, so very, very good question. And I get this question every single time I get this lecture. And this is one of the biggest reasons that patients come to me in terms of wanting to explore endoscopic and surgical management is the fear of long-term side effects of PPIs. And there are PPI side effects. Now, I want to take a step back just for a second and caution that PPIs, for whatever reason, have been out in the news, and it's one of the kind of headline medications that the side effects, for whatever reason, are really publicly out there. We don't see that as much for a lot of other medications. If you can imagine, we hear about all of these PPI studies coming out showing side effects and all these detrimental effects from being on PPI. And maybe it's the fact that the gastroesophageal reflux proponents who want endoscopic and surgical management point these out and are more effective at it than other medications. But we have to be careful that we're basing a lot of our decisions on PPI side effects on good science and good studies, because these have been studied extensively, and many of the studies are not high grade or high quality or good level evidence. That being said, as my disclaimer, there are side effects of PPIs. Most commonly is, and the one that's been studied the most and the one that most people want to avoid, is that long-standing reflux or long-standing use of PPIs. And I'm not talking about 3 months, I'm talking about 10 years, 12 years, have been shown to significantly decrease bone density. So it can cause osteoporosis, or it can cause issues with bone density, especially in an older population. There has been some suggestive link to certain cancers, but that's not based on the best evidence that we have. Most recently, the headlines have been that it's linked to neurologic degeneration, such as Alzheimer's disease. There is some suggestion of that in some of the early studies, but again, it's not at this time based on significantly high-level evidence. So there's many suggested side effects, and there's a lot of studies out there that do point to these side effects. But the long-term high-level evidence isn't quite there to confirm that those are directly related to PPIs and not patients who have other conditions who are on PPIs. That being said, given the fact that we know that it significantly decreases bone density, and there is suggestion that it is linked to some of these other issues, my recommendation is that, if you're on PPIs for 10, 15 years, or it's something that you can't get off the PPIs because you do have significant reflux disease, it's something to talk to a gastroenterologist or a surgeon about, because maybe there is an underlying problem where you're not going to be able to get off those PPIs.
Okay. I started eating more seeds, chia, pumpkin, sesame seed, and flax, because I thought it would be really healthy, but I started burping almost all day. Once I lowered the amount of seeds, it went away. What are the benefits and risks of eating the seeds?
So having a seed-based diet or incorporating the seeds in the diet from a nutritional standpoint is definitely beneficial. And while seeds in and itself are not considered one of the foods that we consider high on the list for producing reflux, it really has to go with how your body is actually digesting the seeds. If during digestion, the seeds, and we see this with things like beans and such, produce gas, then it's going to create more belching and potentially more flatulence also. Remember, the gas can travel either way. The fact that it's actually causing significantly more belching than flatulence may be an indication that the lower esophageal sphincter is loose. But that being said, there's no direct connection between reflux and seeds. It's really how your body is digesting and processing those seeds that can put you at risk of the belching. Also, flatulence is something that you can see with that, and that can lead to reflux disease.
Is it safe to avoid surgery for a large hiatal hernia if the patient doesn't have symptoms?
It is. So when we look at the studies, any hiatal hernia that's greater than 8 centimeters, there's a strong suggestion and a strong recommendation to get that fixed. Anything that's less than 8 centimeters is something that could be watched. Now, when you have a large hiatal hernia and you don't have symptoms, what you also need to be sure of is that you don't have what we call asymptomatic reflux disease. You're not feeling any symptoms, but you're actually having significant reflux. Our body can be exposed to acid, and our esophagus is just so insensate to that acid that while we do have damage to the esophagus, we don't outwardly have any symptoms. And we see that in a lot of patients. So I think a workup to make sure that nothing else is going on is warranted. But if the esophagus is healthy, there's no evidence of reflux disease, and we're solely talking about a large hiatal hernia. If we're talking about anything, my cutoff usually is 6 centimeters, less than 6 centimeters, and there's any reason not to have surgery, or it's just desired not to have surgery, then yes, it is safe to not do anything about it. There is always a risk that the stomach being herniated, though, could become twisted, which is what we call a volvulus. It's a very small percentage of patients, probably in the order of 2 to 3%. So you're always going to have that risk, but it is safe because the risk is so low. Once you get above that 6 centimeter, 8 centimeter, those risks start to go up, where I would suggest consideration of getting that fixed.
Okay, this next question is very pertinent to this time of year. What is the recommended practice of activity after eating a heavy meal? Sitting, walking, etc.
So I always suggest after you eat a heavy meal, now I am a bariatric surgeon and I am a surgeon who kind of looks at the whole picture on patients, is to walk. Exercise, walking, just getting up and moving and burning some of those calories off from a general standpoint is, I think, appropriate. Eating a heavy meal and sitting, usually that food in your stomach can digest, it can create gases, it can kind of keep you more bloated, which puts you at a higher risk of reflux disease. The one thing that you really don't want to do, though, is to have a large meal very close to bedtime. If you eat a meal after 8 o'clock and your bedtime is, say, 10 p.m., that puts you at a significant risk of having reflux disease during the night. Most patients can actually wake up choking during the night. Most patients actually wake up with a burning sensation. And that's the time when, if you have bad reflux disease, you have a large meal and you lay down at night, the reflux that you're experiencing can actually enter into the vocal cords, and that's where patients get damage to the vocal cords and have high coughing. So the worst thing that you can do is actually eat a big meal and then go lay on the couch and watch TV like we all want to do after Thanksgiving. But I suggest walking afterwards. Sitting, I don't think there's anything wrong with that, but I would highly suggest walking after a large meal.
I've noticed that when I bend from the waist, I feel a regurgitation. Is that a sign I should get a workup?
It is a sign that you should probably get a workup. And the reason is that when you bend over, patients also will feel this if they're straining to use the washroom, but you're increasing that abdominal pressure, which we discussed a little bit earlier. When you do that and you bend over and you increase that intra-abdominal pressure and you're feeling a regurgitation of food, that's highly suggestive that that lower esophageal sphincter is not appropriate, meaning that it's not strong enough for the prevention of food from coming up. So increasing abdominal pressure, bending over, regurgitation, that would be a sign that I would suggest a workup to see if you have a hiatal hernia or anything else with the bottom of the esophagus that is allowing that to happen.
Is a flipped large hiatal hernia more likely to twist?
So it is. A flipped large hiatal hernia is something called a volvulus. Now, there's different levels of a volvulus. There's a volvulus where the stomach is simply folded over on itself and there's no harm to the stomach. Now, you can have several different consequences of having a volvulus. If that volvulus were to twist, or if that volvulus were to fold over such that it kinks any blood flow to the stomach, that could cause the stomach to become ischemic and can cause significant issues. If the stomach is flipped and that part of the stomach doesn't allow food to enter it because it's folded upon itself, that could cause early satiety and the inability to tolerate large food. It can increase the pressure in the stomach where the food is present. And can increase reflux symptoms. So anytime you have a large hiatal hernia and they're telling you that it's flipped, or the other word might be volvulus that they use, those are the ones that I highly recommend patients look in or consider getting fixed.
Okay, does anyone else have any other questions at this time? Go ahead and unmute yourself and ask the question or type it into the chat. Yeah, I'm not seeing any more questions at this time.
Right. Well, I just want to thank everyone for coming today. I do have a passion for talking about this, and I want to just thank everybody for showing up.
Okay, we do have a question from Jody.
Hi. I was the one who asked about, I've already gone dairy-free, gluten-free, still having problems. You said there's things that I could do to help considerably. Can you give me a hint? I mean, I'm down to not eating a whole lot of things because everything bothers me.
The question is what would I suggest next?
Yes,
in terms
please.
of diet or just in terms of overall management? If you're
first of all, things to eat. You can only eat so many vegetables and then you get.
Correct. So, every person's a little bit different in terms of the reflux disease and what they are actually able to tolerate. If you have gone down the road of really significantly concentrating on diet, making changes that you think were the foods that were causing the most issues, and you're still having issues, or you've narrowed down that list significantly, my recommendation really would be to get a workup. Make sure that you don't have a large hiatal hernia. Make sure that you don't have significant reflux disease that's causing any damage, because when you get to a point where we're talking about a significant amount of foods that are causing the reflux disease, we're getting away from talking about, highly acidic foods that cause acid. And we're talking probably more about just an overall anatomic breakdown of the lower esophageal sphincter, meaning that anything that you ingest just by eating, because remember we talked about that effacement, and we talked about as we eat and our stomach expands, it increases the chances for reflux. when you're talking about eating foods that don't necessarily trigger acid reflux, but you're getting reflux afterwards, we're going down the road of this being more of an anatomic issue than anything else. So my suggestion would be that it might be worthwhile to see a gastroenterologist to do a workup to find out why that's happening, if it's with foods that typically don't cause reflux. Because in that case, I wouldn't have really any other suggestion in terms of food, because I think it's just the food, the amount of food in the stomach and the eating itself that's causing you to have the symptoms rather than the specific type of food.
Okay, well, thank you very much for coming and presenting to us today. It was
Thank
very
you.
helpful information for a lot of our members. So thank you very much.
Great. Everyone have a great day.
Thank you, doctor. Thank you.